Associate Director for the Center for Middle East and North African Studies, where we study the Middle Eastern and North African region. And that programmatic study has been happening at the University of Michigan since as early as 1889. The center began in 1961, where the University of Michigan has been committed to this area of studies and language training for now over 60 years. Today, we are a designated comprehensive national resource center by the US Department of Education. CMENAS is dedicated to promoting a broader and deeper understanding of the region, its histories, its cultures, its languages, and its peoples through the activities of research, education, and outreach, public outreach programming. I'd like to welcome you to the last of 7 sessions in our colloquium this semester, where every Wednesday for the past 6-7 weeks, we have been conducting the CMENAS Fall Speakers Colloquium. This is a tradition at CMENAS where each fall we bring experts from around the world to discuss and present their research on a topic of current critical importance. And our colloquium topic this term is titled Public Health and Pandemics Across the MENA, a Multidisciplinary Exhibition. Today's session, our final session, considers a behavioral perspective on our semester-long theme and is co-sponsored by the University of Michigan's Global Islamic Studies Center. In previous meetings, we have taken historical, institutional, gendered, lexical, psychological, and physiological approaches to understanding public health and pandemics as they've played out and continue to play out in the region. In today's session, we'll be looking at behavioral approaches. And common to both of our experts today, we'll be looking at one of the important comorbidities that have played out in the COVID-19 fallout around the world, a behavioral phenomenon that has made people more susceptible to, but that requires understanding how and why people engage in this behavior and how this public health behavior can be mitigated in circumstances like pandemics, but also more generally to increase their well-being. As many of you know, we have a 2-hour format where we will first hear from our speakers their prepared remarks for 20 to 25 minutes each. Then we will break for a 30-minute Q&A session with our students and our public that is joining us virtually. And then we'll conclude with a final closed doors session with our students who are enrolled in a course affiliated with our colloquium for a more intimate discussion about our scholars' research and professional backgrounds and experiences. So I'd like to welcome you all today to our final session this semester. And I'd like to introduce both our speakers in the order in which they'll be speaking. First, we will hear from Lilian A. Ghandour, who is an associate professor of epidemiology at the Faculty of Health Sciences at the American University in Beirut. Dr. Ghandour holds a PhD from the Department of Mental Health at the Bloomsburg School of Public Health at Johns Hopkins University. She also holds a Master's of Public Health from the American University in Beirut. Her research focuses on examining the epidemiology of substance use and mental health in the youth, namely underage drinking, prescription drug abuse, and cannabis use. Most recently, her research work has focused on generating local evidence and also mobilizing key stakeholders to push for alcohol harm reduction policies, regulating alcohol availability, affordability, marketing, advertising, and drunk driving. Her work is published in several high-tier international journals and has been disseminated in various global conferences. Dr. Ghandour will be speaking on the topic of alcohol harm reduction in Lebanon, the context, the industry, and the young consumer. After Dr. Ghandour's presentation, we will then hear from Mr. Peter Walton. Mr. Walton has taught English as a foreign language in Chile from 1971 to 1972, then in Portugal and later in Preston College and in Manchester, both in the United Kingdom. At Preston College, he was a lecturer on the outreach programming for local Muslim schools. Mr. Walton holds a master's degree from both the University of Edinburgh and the University of London in history and Latin American studies, respectively. His interests are in the field of public health and education. He's co-authored with Saudi colleagues an article in 2018 in the Journal of Religion and Health entitled Islam and Motivation to Quit Smoking, Public Health Policy Implications. Last year, he published Virtues of the Educator, a translation and commentary on an address given by Paulo Freire, the Brazilian activist and critical educator. Mr. Walton will be speaking on the topic of the role of Islam in public health policy. Thank you for all of you who are joining us. Thank you to our speakers. Dr. Ghandour, the floor is yours.
Thank you, Dr. Hussein, for the kind introduction, and I'm really happy to be here and look forward to our discussions during the Q&A session. I'm just going to go ahead and share my screen. Let me know if you can see it in slide view. Okay. Is it in slide view? Yes, I see Peter nodding. Okay. That's great. So once again, thank you so much for the invite. I'm really happy to be part of this very interesting colloquium. And I know that the theme of the day is looking at a public health topic from a behavioral perspective, but then I was told that I can personalize it to my interests, which I did without hesitation. Because honestly, early on in my career, I was interested in looking at underage drinking and looking at psychosocial determinants of underage drinking. But then, more recently, I've been more and more interested in looking at or generating the epidemiological evidence that would be needed to push for an alcohol harm reduction policy, which is mainly the lion's share of today's talk. Primarily because of the lack of such a policy in the country. I'm just turning on my timer, and the need for it to make sure that alcohol-related harms are at a minimum. So my talk objectives is really twofold. One, I'm happy to hear that the audience comes from different backgrounds and different disciplines, because I am going to spend a few moments talking about the public health approach to alcohol use prevention and harm reduction. What is the public health approach? Why is alcohol a public health issue? And what is the latest on alcohol use, both globally and locally, in the context of the pandemic? The part two of my talk is really sharing with you my experience with developing a national alcohol control policy using the public health approach. I'll be talking briefly about what we found when we reviewed the Arab country status on alcohol data and policy, and talking to you more about the case of Lebanon, which is a very under-resourced setting, So for the non-public health professionals joining us, really the unique features of public health is that much of our work is really grounded in science. So you'll hear us talking a lot about evidence-based planning, data-driven decision-making, and we work with populations and communities. So really, we're always interested to, we don't work on a one-to-one basis like medical doctors do, but we're thinking always in terms of population health and community health. We're very much focused on prevention, whether it's primary, secondary, or tertiary nature, but we are definitely focused on prevention. But really what I want to highlight from this slide is that really our work is very much inherently political in nature, meaning that we really work a lot with the government, or a lot of our work really links with the government, and political commitment is a very either sort of an opportunity or a challenge to the success of our work. I want to share with you a couple of slides. Dr. Zvalko, Pozniak, and others have always highlighted the importance of shifting when talking about drug use disorders, including alcohol use disorders. We've always tried to shift from a criminal justice point of view to a public health approach to dealing with this. And we've always stressed on the importance of continuous dialogue between policymakers and the scientific community. And we've also always talked about the importance of evidence-based approaches, so based on data. This is also always outlined as part of APHA's policy statements. So you can see that some of the policy statements have highlighted the importance of adopting a public health response, or addressing substance use as a public health problem. So why alcohol? Well, needless to say, it is one of the world's largest risk factors for disease and disability, and it is associated with a lot of acute and chronic medical and social problems, and it's no ordinary commodity. And I'd like to think also that it's a public health, but also a sustainable developmental issue, which is why it's really an obstacle to achieving 12 out of the 17 SDGs. And alcohol among the young people is of utmost importance to me because of the sort of array of negative, whether short-term or long-term outcomes among young people. And so since it's totally preventable, and there's something that we can do about it, it's been always an interest of mine. Now, in terms of data, so it says grounded in science here, and I just wanted to highlight again the importance of data. So really, even in the sort of more, in the second updated edition of the International Standards on Drug Abuse Prevention, you can see these sort of buzzwords, right? Information system, regular collection and monitoring of data, prevalence, all of this feeding data. So really the importance of, any, whether we're looking at tobacco or alcohol or any public health problem, we can't stress enough the importance of generating data and let all our prevention and interventions be data driven. I'd like to, speaking of data, I'd like to highlight here, for example, some international endeavors, such as the Monitoring the Future study. So this is the study that's been collecting data on national survey estimates since 1975. And having such data over time is really crucial to potentially not just understanding the epidemiology of public health problems, but also trying to see indirectly the impact of macro level factors such as the pandemic. So I'll show you in a bit. So this is, for example, a slide from the latest report. So as you can see, alcohol drinking has been declining over the years, but you can see that in 2020. And so they say here that the 2020 panel data was collected from March 2020 all through November 2020, so early on in the pandemic. So you can see that maybe such data could be capturing somewhat the probable impact or possible impact of the pandemic, which we'll probably see more clearly in the 2021 data sets. And actually, the impact of the pandemic on alcohol use has been tackled widely by the global scientific community. And as you can see, there are multiple publications that have actually shed light on how the pandemic has either increased the number of people who have initiated alcohol use or actually increased frequency and amount of drinking among the alcohol users. Now, this is global. When looking at it from a regional point of view, you can see that really there's much, much less done in terms of evidence generation. So these are two publications on the impact of COVID, but you can see that they've really looked at the impact of COVID on substance use services and also on programming. But nonetheless, ESCWA has, indicated that really we do expect that, this prolonged lockdown has, most definitely had a mental health impact and a toll on the population. Now, with regards to Lebanon, we've been grappling with the COVID pandemic since the start, since February 2020, but we've had our own unique compounding crisis. So beginning October 2019, we, when the economic and financial crisis started, and it's just been getting worse and worse by the minute, if I may say. It's been ranked as being possibly the top 3 of the most severe crises globally since the mid-19th century. And so you can see, you can guess or estimate the impact of this on people's mental health and substance using behaviors. Also on August the 4th, 2020, Lebanon, Beirut witnessed one of the largest explosions in history, which left 200 people dead and many, many more injured and caused a lot of infrastructural damages. And so you can see that we were not just literally grappling with the COVID pandemic, but multiple other compounding crises. Now, for those of you who don't know where Lebanon is, it's a very small country in the Middle East, right here. But it has a very unique position, being at the crossroads of land and sea routes that link Europe, Asia, and Africa. And it's renowned for its cultural diversity. We've got a large Muslim, but also a large proportion of Christian population, and it's really known for its cultural openness. And before the crises, student surveys had indicated that drinking was starting as early as 13. So this is from school-based surveys among 7th, 8th, and 9th graders, pretty much mimicking the MTF survey from the US. We have learned through a time trends analysis that really more young people are drinking, specifically female. So there's a narrowing in the age and the gender gap. Drinking is more regular than occasional among this group of young people. And honestly, we found a large association between alcohol use and other mental health problems, including prescription drug abuse and gambling, as well as suicide. Now, one might think, okay, so what has happened since the crisis or during the crisis? So a group of my students were interested in looking at that. So they conducted an online survey in March of 2021, and they asked participants to report on whether their drinking has actually increased, decreased, or whether they started drinking between March 2020 and 2021. And so you can see here that among the 18 plus, or even among the 18 to 24-year-olds, about a third of the past year users reported either initiation or increase within that past year. And this increase was higher for people with higher levels of stress, as you can see here. So the higher the level of the stress, the higher the percentage of young people who reported initiation and or increase, higher with higher levels of depression, and higher with higher levels of anxiety, as expected, but this is the data speaking. So part two, and so, this is the part that I'll spend most time on. So really part two of this talk is really, to shed light on the successful components, but also the challenges of trying to develop a national alcohol control policy using a public health approach in the case of Lebanon. Now, before moving on to talking about, the alcohol harm reduction policy that we tried to develop, I want to highlight that basically risk factors for alcohol use underage drinking is really multifactorial. So you've got risk factors at multiple different levels, whether it's the individual, the family, the school, and the community. And this is why from early on, we know that strategies to curb underage drinking could be school-based, family-based, or even policy and community-based. But this is where my focus is going to be today, because we know from international standards on drug abuse prevention that really without a supportive policy and legal framework and coordination among the different multiple sectors, we can't achieve much. And also, just to let you know personally, the reason I became so much interested in generating evidence for policy is because when we analyzed the data of the GSHS, so for those of you who are not familiar with that, this is the Global School Health Survey that is conducted in member states of the WHO, funded by CDC and local ministries of health, of education. So for Lebanon, when we analyzed the data from 2005 and 2011, we found that really there was an increase in drinking, but more so findings such as 87% of the lifetime drinkers beginning having their first drink before the age of 14 clearly has implications on has policy implications. So things like enforcing a minimum legal drinking law, which doesn't exist for Lebanon, becomes a priority. Now, sure, we want to restrict home availability. We want to encourage parent-child communication about the alcohol-related harms, but there's also much that can be done at the level of policy. So what we ended up doing is myself and a multidisciplinary team that I'm going to be introducing later submitted for an IDRC grant. This is a Canadian funding agency, and we secured a grant to really try to shape and improve the quality of the debate in the Lebanese policy environment, because despite the cultural openness of Lebanon, nonetheless, alcohol is still sort of a socially taboo or sensitive, let's say, topic to be discussed. And so basically what we wanted to do is improve the quality of the debate, try to place it on the policy agenda, and therefore ultimately reduce alcohol-related harms. Now, Lebanon is one of 22 Arab countries with varying dispositions with regard to alcohol sale and consumption. We've got other countries from Libya, Saudi Arabia, and Somalia, Sudan, and Yemen, where alcohol is totally banned. But nonetheless, like I said, even in countries where alcohol is not banned, even in Arab countries where alcohol is not banned, you can sense the social taboo linked to alcohol use, which could be leading to underreporting of its consumption and purchase. So what we ended up first doing, the first step was we thought, okay, so let's benchmark and try to understand what's the alcohol policy situation in other neighboring Arab countries, and what is also the epidemiological evidence. So what we found in brief is that really there's very little written on alcohol from the and published on alcohol in the Arab world. So in 21 years, from 1993 to 2014, and across 22 countries, there were only 81 alcohol relevant published articles compared to 255 on tobacco. And I guess the worst part for an epidemiologist is our inability to compare the data and the findings because of the heterogeneity of the methods used. And so really very little conclusions could have been deduced by comparing these studies because of the, like I said, the different methodologies that were employed. From the policy perspective, we found that only 4 out of the 21 countries had adopted a national alcohol control policy, but some other Arab countries were implementing specific components of such a policy. For example, 8 had a law enforcing a zero alcohol limit for drivers. 6 countries had excise taxes. 4 countries had restrictions on alcohol outlet density. But the most interesting and mind-boggling part was that several countries had more than 75% of their data fields missing. So this is a very complex table, but I just want to highlight here that if you could just focus with me on Lebanon, you can see for the most part, it's all dash, 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 dash. And what dash is that the data is either missing, or as we found out after a very deep in-depth content analysis, that if it wasn't missing, it was actually there, but the last time it was updated was from the 1930s or the 1940s when Lebanon was really under the Ottoman Empire, or even before that. So what we ended up doing for the 22 countries or 21 countries is grouping them according to their alcohol ban stance and their epidemiological evidence. So countries such as, for example, KSA, right? They have an alcohol ban, but then a lot of their clinical surveys, so clinical sample surveys, indicate that their alcohol-related problems do exist even among the Saudi nationals. So our recommendations were then to strengthen existing resources and make sure that there are, equitable and affordable treatment services for everyone, for all residents. Countries where there is an alcohol ban, but there is no data should probably learn from the case of Saudi Arabia, which means that the absence of, the presence of a ban doesn't necessarily mean the absence of a problem. And so for those countries, we recommended basically the collection of data. And then, of course, for countries such as Lebanon, where there is no alcohol ban and there is data suggesting that alcohol is common and potentially problematic, we felt that the next step was really to push for an alcohol control policy. Now, for those of you who are familiar with the WHO best buys, the best buys are really basically policies that regulate affordability, availability of alcohol, regulates marketing and advertising, and also drink driving. So these are sort of the core policies that should exist within each country, but there are also, of course, some of the expanded and more optimum level of policies. So in line with the WHO best buys, when we did focus group discussions with young people and we asked them about, basically the determinants of underage drinking, you can tell from their quotes that pretty much most of their quotes are related to policy, So you can see that when they say things like, it's very easy to get a drink, no one asks us anything, or I'm under 18 and no one asks us for our ID, or many stores do sell alcohol, that's clear indication that there's an absence of policy and we need to do something to make sure that these policies do exist. And so we ended up conducting multiple different mini studies. So what I would like to call it is like trying to look at the different pieces of the puzzle and then putting it back together. Obviously, I don't have time to present the data, but what I wanted to highlight really is this, the clear industry resistance to change. So when we talk to different stakeholders, as you can see on the right-hand side, and we asked them about what could be possible challenges to policy implementation, it was clear that, for example, the Ministry of Finance or the Syndicate of Importers of Foodstuff, Consumer Products and Drinks were not on the same page as us, because they were saying things like advertising bans don't work, taxation doesn't work, we need to be promoting self-regulation and we need to be promoting corporate social responsibility programs. But with all these challenges, there were major successful elements that I wanted to highlight to the audience. So number one was the multidisciplinary team. Again, I mean, without this team, very little could have been done and very little could have been achieved. And, we started small, but then we started adding collaborators and consultants with, different expertise and experience. So we realized that none of us at all, from the core team could be evaluating policies and laws and stipulations, because this was like, it needed a pure lawyer. So my first advice is to always make sure that you have you work collaboratively, and that you engage a multidisciplinary team. Always follow a participatory-based approach. So what we did is we always engaged various stakeholders at all times from the start of the project, not brought them in towards the middle or the end. So we told them from the very beginning that these were our intentions and that we were going to be inviting them on multiple different occasions for their input. We mobilized allies in the community. So a lot of the NGOs doing great work were actually getting funded from alcohol distributors as part of the CSR. So what we did a lot of workshops talking about conflict of interest, corporate funding in public health, to sort of sensitize them to the issue of conflict of interest. We engaged various stakeholders. Many of these attendees are people who are policymakers or policy implementers, and we tried as much as possible to have several dialogues with them to make sure that, again, they are on the same page, or trying to get them to be on the same page. Like I said, just generating different pieces of the puzzle is not enough. We need to triangulate the data once collected and make sense of it and disseminate it. So as much as I'm a big fan of publishing in peer-reviewed journal articles, also I felt like it's really, really important to disseminate in multiple different formats. So whether it's a policy brief, or maybe like a small piece to the media, whether it's written media or TV, or just try to sensitize the media and spark their interest, because their support is very, very important. Engage. Sorry.
Pardon the interruption. Just FYI, we have 5 minutes.
I'll be done before. Thank you. Thank you. And so it's important to also engage with scholars and learn from other people's experiences. So for example, the Australian experience, the Scottish experience. So being on a regular dialogue with scholars from different parts of the world will get you also, the knowledge sharing part is very, very insightful. Seize local opportunities. So back in 2016, the Ministry of Public Health in Lebanon decided to develop an interministerial substance use response strategy. So we engaged with them, and we also engaged with other NGOs that are implementing prevention programs, and always seize the global momentum. Now, if there's anything that I want to again highlight, is that one of the successful elements is anticipating or actually preparing for threats and challenges. Now, whereby some threats are really very hard to prepare for, such as the blast or any of the compounding crises that we've been going through. Trying to find sustainable sources of funding, trying to engage people, different stakeholders, is very, very important. And not just to sort of stand in the way of the vested interests of the alcohol industry or the alcohol distributors, but also to be prepared. So again here, if I were to summarize, I would say that the public health approach starts all the way from identifying what the problem is, defining the scope, understanding international evidence and standards. So we couldn't have really built a national control policy without really understanding what's going on in the neighboring region or in other countries, working with a multidisciplinary group, collecting, analyzing, and triangulating data, disseminating it with the right stakeholders, and also always evaluating either the strategies, the interventions, or the strategies. Now, I thought I'd conclude with this slide, because unlike COVID, there is no magic bullet to addressing the underage, the issue of underage drinking, which is a major public health problem. But I mean, there is hope. I think just like the alcohol molecule, this is basically, people who are chemistry in the audience would appreciate this, but pretty much similar to the alcohol molecule, I feel like it's just a situation where we need all stakeholders working together, be it NGOs, parents, youth, physicians, law enforcement policies, but most definitely the policymakers, in order to achieve some success. So thank you so much, and I hope I did not go over the 25 minutes.
No, thank you very much. It was very well timed, but more importantly, very, very interesting and informative. Peter, if you're prepared, you can go ahead and start now.
Thanks, Dr. Hussain. Can you hear me okay?
Very well, thank you.
Okay. Well, I probably don't need to convince you that public health is a political football. After all, the United States is a country of Medicare for all, or almost. I put my cards on the table. My objective today is really to try to convince you, if possible, that pandemics will be with us until we come to view them as not as pandemics, but as syndemics. And I'll explain what I mean by that in a minute. But the consequences of that are that we apply politically informed solutions to the problem. Now, there are communicable diseases like COVID, severe acute respiratory syndrome viruses, and there are non-communicable diseases, which include things like obesity, cardiovascular disease, kidney failure. We could go on. Now, communicable diseases are pretty scary. We think we're going to catch them off somebody. We've seen probably too many zombie films. Now, in contrast, non-communicable diseases are pretty non-scary. But we must think, I think, both of them as syndemics, not pandemics. And in particular, tobacco use as a syndemic. Now, pandemics like COVID have got a lot of publicity. I mean, we're looking at what, 5.5 maximum million deaths recorded since beginning of March 2020. Well, that's in about 18 months, okay. Tobacco kills about 6 million people a year, tobacco-related diseases. So it gives you some idea of the scale in comparison, although of course, the statistics are just ballpark figures, but have some basis in fact. Now, a syndemic does not imply a purely biomedical approach that tobacco use or COVID is a purely biomedical issue. If you've been watching TV in the UK, I don't know about the USA, but the government experts come along with the Prime Minister and tell us all about numbers of casualties, number of deaths, and a number of people who've been vaccinated, first and second dose, etc. This implies that the solution is drugs, hospital treatment, so on, completely ignoring social factors, education, employment, housing, food, environment, and in particular identifying vulnerable communities. We were shown, for example, pictures of areas in UK which have large Asian populations, first, second, third generation, as hotspots for COVID. Well, it was left at that, well, why, So I think we need to adopt the approach recommended by the medical journal, The Lancet. It was an editorial in 2020. And that was suggesting that we view pandemics as syndemics, okay. The World Health Organization in 2004 had a leaflet on tobacco and poverty. And that suggested this syndemic approach. And I was reading an article on Iran the other day in the East Mediterranean Health Journal, published in 2020. And that was suggesting that not only is tobacco-related deaths and tobacco use more prevalent in low and middle income countries, but within those countries like Iran, it's people with low economic status. We won't go into how all these things were calculated, but you get the general picture. So, okay, that's what a syndemic is, viewing the thing as a total, with all these other factors coming in, not just biological, but social. Now, we could take as our starting point about tobacco use chronological. A lot of studies do that in different things, but that would take us back to Morocco in the 16th century. So we won't go there. We'll instead take a geographical starting point. And the first thing I'd like to point out is that the Middle East itself is not equivalent to the East Mediterranean region, which is one of the 6 regions of the World Health Organization. There are 22 countries in the East Mediterranean region, and they include countries like Pakistan, which might at first glance seem strange. Morocco, well, you wouldn't call that Eastern Mediterranean. Israel isn't in there. Stranger. Well, World Health Organization was formed in 1948, so Israel was just being formed as a state. The obviously political ramifications of that. Similarly, Pakistan was breaking away from India, becoming independent. India is in the South Asian region. So, okay. Now, one surprising omission, if we say, okay, well, maybe the World Health Organization decided that in the East Mediterranean region, we should be grouping all the Islamic countries with large Islamic populations. So why didn't Turkey get in there? That's part of the European region. I find that strange. The only hint I've been able to find through all the World Health Organization documents is that it was arranged this way for organizational and administrative convenience, which doesn't help much. Okay. Now, the paper which I wrote together with my colleague Khalid from Saudi Arabia was entitled Islam and Motivation to Quit Smoking, and we looked at the public health policy implications of that. Does Islam, or does religion in general, or does Islam in particular have a key role to play in reducing tobacco use? That was our question. Our answer was that we think it has a role to play, but it can't be the pillar of a tobacco control program. Like Lilian was saying, that has to be evidence-based and has to be directed, administered by public health experts. That's not to say that civil society has no role to play. All these contributions are welcome, and they're all part of treating this as a syndemic, not a pandemic. Okay, 22 countries, Middle East and North Africa, headquarters in Cairo. Faith-based approach, that's one of the terms used by the World Health Organization in one of its publications, I think 2011. Now, I find it strange that there should only be 2 framework conventions that the World Health Organization has organized. One on climate change, which you've probably heard about, Framework Convention on Climate Change, very much in the news. The other, the Framework Convention on Tobacco Control, put into operation in 2005, and something called the Empower measures 3 years later. Empower, monitoring tobacco use, gathering evidence for that evidence base we were talking about. P, protecting people from tobacco smoke. What does that mean? Well, the obvious: restaurants, public places, smoking bans. Offering help to quit. Good idea, but are the smoking cessation services in place? Very uneven throughout the region. Jordan, for example, will offer you free nicotine replacement therapy, primary care, which is geared up to helping people to quit smoking. Smoking cessation clinics are there in Saudi Arabia and other Arab countries. Phone lines, quit lines to help people, and also to help in surveys, which is something which Lilian's familiar with. Warning about the dangers of tobacco, you can all work out where that comes from. Tobacco, warnings on tobacco packets. Enforcing laws on tobacco promotion. Yes, okay, alcohol ban in Lebanon, for example, but enforcement is uneven, sure. Raising taxes on tobacco. The WHO and other studies have said this is a key one. This is the biggest single thing you can do to reduce tobacco use. Hike the price up. Saudi Arabia, what will you pay for a packet of Marlboro? Well, they put a big price hike up in 2017. They doubled the taxes. You pay about $7 now for a packet of Marlboro in Saudi Arabia. I don't know what it is in the States. It's eight and a half. And if there are any smokers out there, you can tell me. So these are the basic measures. Okay. So where does religion fit into any of these? Well, probably in warning about the dangers of tobacco, I would say. Now, it's not easy because I was looking at a recent study. There was an attempt in 7 mosques, I think, in the UK to involve the religious teachers in the mosques in promoting tobacco use, promoting tobacco cessation and prevention. In other words, among never smokers, trying to get them never to smoke. It came across all kinds of cultural and other difficulties, but those who carried it out, this was 2017, reckon that with a little bit practice and so on, it could be extended. My own experience of teaching in Muslim schools and madrasas over 2 years, I'm inclined to agree that it is possible and there is a willingness to do that. But this is purely subjective. I have no evidence for that. Okay. Now, the study that we did, Khalid and myself, looked at what we thought were teachable moments when religious awareness was in Islam was at its height. Ramadan and Hajj. Well, a few things about Ramadan. Smoking is anyway not permitted between sunrise and sunset. And there have been a number of studies done on smoking reduction during Ramadan. Kidwai in Pakistan, for example, the Aga Khan University did one. They haven't all looked at whether people were smoking at night after dark. So you need to establish that, because if people are smoking at night, then they've not really quit. So quit attempts have to be judged on that basis. During Hajj, well, the Saudi authorities have, I think since 2000, declared the holy cities of Mecca and Medina smoke-free zones. It hasn't happened, and it's a vision for the future. It's something that it's working in part. We've got some evidence in our article that the Saudi authorities have done on that. One thing we have to say about all these statistics that are produced is something which Lilian said, that it's all self-reported. So there are pressures to say you're not a smoker or to say you're not a drinker. Whatever kind of survey you do over the phone, household, self-reporting has that difficulty. So we have to bear that in mind. Well, during Hajj then, the combined populations of Mecca and Medina were about 3 million people. That just about doubles during Hajj. So, okay, a lot of the pilgrims are Saudis themselves, but especially during COVID. But many come from outside, and there's a lot of work being done by the Saudi authorities to promote posters, leaflets, and so on, warning of the dangers of tobacco use. There are two possible approaches that can be adopted throughout the Middle East and throughout the world. One is this kind of educational approach. The other is a kind of coercive approach, fatwas, bans, difficulties of enforcement, of course. These two things are, there's no reason for them to be seen as opposites or in contradiction. There's no reason why they can't go together. It's similar to the question of addiction, choice, or compulsion. Do people take up drinking, smoking, other drugs? Have they done a risk assessment of, oh, well, yes, it's not going to do me much good, but the enjoyment I get is going to be more than outweigh that. So I'm going to take up smoking. No, I don't think that's how it happens, but you may have your own views on that. Well, our conclusion really is that Ramadan and Hajj are teachable moments, and that there's no reason why, I can't see any reason why religious leaders in Islam cannot participate along with the rest of civil society in encouraging people, making them aware of the laws, making them aware of the dangers of tobacco, pointing them in the right direction to whatever services are there. We need all the help we can get, because especially in preventing young people from taking up smoking. Tobacco is one of those industries, it's not the only one. It's one of those industries that kills its customers. So you start taking up using tobacco, you're going to be dying at an earlier age. So the tobacco industry always needs younger people coming in at the other end to keep the production line going of consumers. So it's a big job that civil society has to play in resisting pressures, all kinds of pressures. The industry is very clever. To take up smoking and give it a good image and so on. And there's all kinds of ways around that. Price shifting, so that if taxes are raised on cigarettes by a government, the cigarette companies raise their prices a lot on the more expensive brands, which more richer people can afford. But then again, on the cheaper brands, they reduce the price a bit. That's one thing. In terms of promotion, you may have seen some of your friends on the internet or Facebook, Instagram, having a smoke or having a drink. That's another way that tobacco companies get around the laws against tobacco advertising, get people to do that on their Facebook pages as private individuals.
Peter, sorry for the interruption. We have 5 minutes remaining.
Right. Okay, Dr. Sain. Let's finish with that then. A final thought.
I have a quick question for you, Peter. We do have 5 minutes left. I was wondering if you could, for our benefit, state what the major finding or findings were of the study you cite that took place in Saudi Arabia.
Could you repeat that, Dr. Hussain?
Could you state the finding or main findings from the publication you did in Saudi Arabia looking at tobacco use?
Sure.
No need, of course.
Yeah. Okay. So let's finish with that then. Our conclusions were that there's no firm evidence that would support the idea of making Islam a particularly important foundation for the policy of reducing tobacco use. But we do think that it's an important element, as far as we can tell, in supporting the health-based, evidence-based approach that the World Health Organization is recommending across the globe. And that Islam is particularly well placed because of the particular strength it has within Muslim countries to do that, to play that role. We think it has a role to play. And more work, it's like Lilian said about Lebanon, more work needs to be done to try and untangle what works and what doesn't. But it certainly won't do any harm. And the policy of reducing tobacco use needs all the help it can get because it's up against big enemies. Let's finish at that, Dr. Hussain.
Well, thank you very much, Peter and Lilian, for both of your prepared remarks. This will conclude the session of delivering your talk. And now we'll move into the 30-minute session with the public. And of course, we have our students in the classroom, but we also have online participants. For those of you who are joining this colloquium for the first time, especially online, please make use of the Q&A tool, usually located on the bottom of your Zoom screen. It literally says Q&A, and use that tool to type in your questions, and I will bring them into discussion over the next 30 minutes. Just as a way to kind of recap what we've learned and what we've witnessed in both of your remarks, I think I'll just try to get the conversation going by framing it a little bit to contextualize. So, you know, Lilian, in your work, I took broadly the understanding that public health is incredibly complex work to be done, but there's a common understanding that evidence, the scientific method, are the primary vehicle by which we begin with assumptions, but then navigate into the real world of trying to deliver an impact on the world in a situation which is obviously highly complex. And I sensed a great sense of resource limitations. So there are competing forces and factors, but if we're trying to have an impact on a specific behavior, let's say in your case, looking at alcohol reduction, you can, not only are you working against competing forces, but you're also having to choose a certain vehicle to do it. And I think from your talk, I took the indication that public health policy, where the state can play an important role in articulating and also supporting, but then also enforcing that policy, can be, of the competing vehicles, maybe the most impactful one. Peter, in your talk, especially the research article that undergirded much of, I think, the information that you changed, I took it more as a test of some of that approach. So you indicated that the World Health Organization has a guiding framework, and in that framework, religion, in religiously based, organized, and instated societies, religion could play an important role in delivering public health impact. And I believe, if I heard or took the correct understanding, you and your colleagues investigated the role in which Islam could play in a religious society like Saudi Arabia to make an impact on smoking behaviors in a time when you would be most probable to see that impact. So in cases like when people are fasting or doing the Hajj, where the religion, broadly speaking, across its diversity, encourages smoking cessation, to what extent has religion been the variable that has the most impact in reducing smoking cessation? And I think your conclusion was at best ambiguous, but perhaps even more so. I think I heard you saying that religion may not be the most obvious vehicle, although there could be a role. So I wonder if a correct way to summarize that is to say, religion, according to your study, specifically Islam, could play a necessary but not a sufficient role. So it's a complicated kind of, I think, conclusion or argument that you're proposing. Now, this is the broad kind of comparison that I'm making across the 50 minutes or so of discussion. But I'll allow the classroom and the public to start with any questions they have. But I also see Lilian, your hand is up. Actually, why don't we turn to you, Lilian, and then I'll collect questions and topics to have.
Just a super quick intervention. So first, we would like to think that data is the thing or the component driving most of the policies that we are, or that's what we would, this is kind of our wishful thinking as academicians and prevention scientists. But sometimes the reality is that you need someone from the inside to champion the cause, to lobby for the cause, to advocate for the cause. And that someone could be one of your policy implementers or developers, championing that particular cause. So in reality, and that's what happened with regards to Tobacco Law 174 in Lebanon, it was only when one of the members of the House of Representatives started, championing the idea of passing the tobacco law that it actually started gaining momentum. So regardless of all the evidence that is accumulated over so many years, it was only when one member from the inside, so let's just, in terms of when you get textbook versus reality, so just to be a little bit more realistic. The other point that I wanted to quickly make is we've done a lot of work, and I know that Dr. Hussein approached me the first time to talk about religiosity and bullying, and we had a lot of my research has looked at the role of religion and religiosity with regards to multiple different outcomes, including gambling, more recently food waste. But with regards to alcohol, I want to share with the group that there's a very important and distinct difference between, and a distinct difference to be made between religion and religiosity, right? So we're talking about religion being like Islam versus Christianity versus, for example, the Druze population in Lebanon. But what we found is that while Islam as a religion could potentially delay or reduce the initiators, alcohol initiation, once you're a drinker, we found that what really matters is religiosity. To what extent do you practice your religion, regardless of what your religion is? So both Christians, Muslims, regardless of their religious faith, if they practice their faith, they were at a much lower odds or risk of developing alcohol-related problems or alcohol dependence. So I mean, this is a very important finding because in this part of the world, Lebanon and the Arab region, when we talk about our religion, we talk about it as our self-identity. So I remember living in the US when someone said, I'm Catholic, that meant that I'm actually a practicing Catholic. That didn't mean, it meant a lot about practices, whether they are practicing Catholicism or not. In Lebanon, you could be, you could be Sunni, you could be Muslim, you could be anything, but you could pretty much not practice any of those doctrines, that your religion asks you to. So you need to further, try to assess whether this person who's a Muslim or a Christian is actually practicing, that religious doctrine or not. So I think and I agree with Peter that there's a lot to be done there because we found that religiosity reduces food waste, alcohol-related problems, but not necessarily religion per se, but whether they practice their religion or not. So thank you for providing the time to just make that clarification.
Thank you so much. Do we have any questions? Heather.
Hi. So I'm a dual student in Middle East Studies and social work. And in social work, we often think about substance use, whether it's tobacco use or alcohol use, etc., as like coping mechanisms that our clients use to survive their circumstances. And we can view recovery as like a recognition that substance use, that coping mechanism is no longer serving them. And so frequently what my clients are coping with, at least in Detroit, but also through my work in Amman, is kind of environmental and societal factors more so than like personal circumstances. So like, for instance, the Lebanon example you talked about, like unemployment, corruption, limited opportunities that make it difficult to like imagine a future, things like that. So I wonder, and like boredom is something I hear like so often. And so I wonder if there's room within the public health and within like, or within the faith-based framework of interventions that you both talked about for addressing like these root causes when we're thinking about prevention versus like the more maybe like individually focused approaches like education, legal repercussions, or like protective factors that like individuals may have, but thinking more about like kind of like those crises that you talked about Lebanon is experiencing and like going at those at the root at a policy level. I don't know if that makes sense, but
No, you make a lot of sense, but I missed the question. So
like how maybe whether it's like Lebanon specific or just like in your public health framework generally, or even in what Professor Walton talked about, the faith-based framework of like how can we both address like education, legal,
yeah, okay, I get it. Okay, yeah.
causes.
So in one of the slides, yeah, that's a great point, right? Because like I said, like one intervention working in silo will probably not work. So we have to think of, whether we're thinking any kind of substance use prevention, it really needs to be a comprehensive one. And I know that sounds cliche, but that's the only way it'll work. You need the involvement of the family. So if we're talking alcohol, for example, you can't serve your kid alcohol at the age of 10 thinking, it's okay, he's doing it right in front of me, it's much better than if he does it right behind our back. We've got Drs. Volko and others talking about, the importance of making sure that young people don't drink this early on because it'll affect their brain development. And so that needs to be, worked on with the parents, right? And the family who are, who misperceive, the extent of which, the extent of harms that, early on drinking can make. But you're right, there's schools, there's the work, that NGOs and schools can do. But what I was trying to sort of maybe stress in my talk is that regardless of what the parents are doing at home or what the schools are doing or what the individual is trying to do, right? The fact that they can still walk into the supermarket, right? And buy, and pick up a beer, which is probably cheaper than, iced tea in Lebanon, and then walk out without an ID and then be able to drink and drive and all of that. It's very hard to sort of, and so you will end up doing a lot of victim blaming, right? I mean, saying that it's all, at the level of the student or the young person or the parent or the school, when in reality, the structural determinants of health are really problematic in this case. And I agree with you fully. Many young people use it as a negative coping mechanism. And this is what we're seeing in Lebanon, but also, I mean, we're seeing this globally now with the pandemic, but you can imagine it being much worse with the compounding crisis. So I hear you, and this is why we need to sort of make sure that I always compare it to like building a building, right? You start with the foundations and then you sort of build the other stuff, but without the right foundations, which in my mind is the policy framework, it's very hard to achieve anything. I hope I answered your question.
Yeah, totally, thank you.
I have a bit of a follow-up question or building from that discussion to Peter. Peter, if we begin with the premise that institutions are incredibly important in leveraging their effort, their resources, the policy and enforcement to change public behavior to be better to itself and to society. I'm curious, based on your biographical information, teaching critical pedagogy, through the work of Paul Freire, working and teaching in the various societies in Latin America and the Middle East that you have done yourself, I'm interested to get your take on, you mentioned in your presentation a few times, the role of civil society. And by civil society, I don't mean to say it's not an institution, but we can say perhaps it's a counterbalancing institution to state institutions. So I'm curious what your line of observation or thoughts are in how you see civil society playing a productive leading role or a collaborative role in working with state effort or state institutional effort.
Okay. Well, in terms of the main focus of our presentations tonight, which is the focus on addiction, the role of civil society. Well, there are two aspects to addiction. I'm probably oversimplifying this, but motivation, either to continue smoking, to take up smoking, or motivation to quit smoking, and dependence. Now, I would divide dependence into physical dependence on your nicotine intake or your alcohol intake, and cultural dependence. Let's take a phenomenon that's not confined to the Middle East, which is water pipe smoking. Quite big in the States, I think, I don't know, but that's a kind of cultural thing, a kind of social event, which probably has been affected by the COVID situation. Again, I'm not sure. But okay, so in terms of cultural dependence and in terms of motivation, I think religious institutions and all of civil society, even from the household level upwards, can influence people either to not take up smoking, which is very important, or to cut down and quit. And if possible, voluntary bans on smoking, say by restaurant owners or cinemas. All these things would help. Schools, for example. Now, are there programs in schools to tell people about public health dangers? There should be. Environmental factors. Well, how do we organize our cities so that there may be a way to discourage alcohol abuse or tobacco abuse? There's something there for all elements of society to get involved in. And where there are already strong influences, and this is where I think Islam comes in, is then we've got to approach and try and get them into partnership. I mean, okay, I take the point that public health and religion don't always go eye to eye. We only to think of the questions of abortion and so on, family planning. The two things may not always go together, but in most public health issues, they do. So I think there's a need for general involvement, if that answers your question.
Thank you. Questions from the audience?
Could I just make one further point, Dr. Hussain?
Of course.
That religion can come in, as I said, where motivation, in terms of motivation, not in terms of physical dependence on nicotine. And we could talk about electronic nicotine delivery systems and all sorts of things. But it's been shown by Vangeli and others in a study that high motivation to quit is associated with making quit attempts in terms of tobacco. And if that can be combined with low dependence on nicotine, then you've got a formula for possible greater success than if you have a high dependence on alcohol or a low motivation to quit. So it's a combination of those two things. And we think, that religion has a part to play in high motivation, inspiring people to make quit attempts.
Actually, Peter, this reminds me, when you were speaking, it was the first time I had heard of this concept, syndemics. In fact, I completely misunderstood in the beginning until I looked it up. And I believe you're citing, you mentioned it, an article in The Lancet, which describes, I believe, the work of Merrill Singer, who is a public health scholar at the University of Connecticut, who provided a framing of understanding epidemics in a synergetic fashion. So a combination of preconditions that come together, I presume, in not a very good or very highly potent way. So I just wanted to provide some of that background. Can either of you, Lilian or Peter, can you speak a little bit more about or defining a syndemic in the way that academic concept has provided an alternative to thinking of pandemics in the way we usually think of them? What's the difference? How do you define a syndemic versus a pandemic? What's the critical difference between the two?
Do you want me to take that, Lilian, or okay? Well, I try to look at it this way, that I gave you the example of the UK. You'll know yourselves from the US. Imagine that every night in the UK for about a year, we had the Prime Minister coming on with the Director of Public Health and so on. And every night it was about the same thing. It was about numbers of people who've been vaccinated, number of cases, number of people in hospital, number of deaths, just treating it as a purely biomedical problem. That's the pandemic. That's how you would look at a pandemic. And where broader things were brought in, like, okay, there's a hotspot near Manchester. Now, that's where there's a large Asian community, for example. Okay, so it was just left at that, you know, no explanation of, well, why is it there? What is it about this culture, or is it just an accident? No, it wasn't a one-off. There were other places in the East Midlands where, again, there's a large Asian population. So just discussing that in purely biomedical terms is missing out a lot, I think, about gaining an understanding of what's happening and therefore being able to do something about it. So looking at these other factors, as I said, education, environment, housing, food, all these questions and many others coming into it.
That's very illustrative. Thank you. The way I summarize from that and take from it is, you know, I'm a classically trained social scientist in the quantitative predict and in normal distributions, tradition. And one of the things that's happened in my own academic career, as I study more complex phenomenon at higher levels of abstraction, going from individual behavior to, let's say, nations' behaviors, looking at nations as entities that behave in certain ways. One of the things that's happening in these arenas of academic work is to go beyond covariates and variables that can be boiled down in tables, and instead look at complex systems that are themselves embody many variables. So the variables that play in defining state behavior are confounded with the behavior of markets, which is, you can, of course, you can table everything, you can flatten the dimensions of everything. But I think you lose in that exactly what you're talking about, the synergetic complexity. And so kind of turning back to Lilian, I was very intrigued when you were speaking about the methodology that you use in generating research ideas and how you pursue them. You spoke in one of your steps, the critical importance you found in doing participant observation on the early end of the research process. I'm curious if this context, or more specifically to why and how you found participant observation, if you could speak a little bit to this, because I find, even in my academic disciplinary vestiges, participant observation is less valued compared to how important, how commonly it's valued in more applied social science settings like public health. So there's a great appreciation that I see, a practical utility in disciplinary areas where you have an obvious problem to solve. It's not just an intellectual puzzle. So I'm very curious to see how this complexity factors into why you deem participant observation so critical at the beginning.
So, just to sort of make sure, are you alluding to the idea of participatory based approaches, or what is it? I don't think I mentioned participant observation.
Good.
So,
a very important point to clarify, I think. I was more interested in the general appreciation you have for participatory methods.
yes, okay, so yes, I agree. Yeah, okay. So in the context of alcohol per se, when you're dealing with, when you're within a, so I'll give you maybe a little anecdote that would help shed light on this issue. So I was once invited to a TV show to talk about our project, and we intentionally, by the way, use the words alcohol harm reduction. And so it's not, so that it's not misconstrued as we're trying to prohibit alcohol in any shape or form in Lebanon, because, that creates some sensitivities. And we intentionally focused on young people because we figured we can get the buy-in of almost everyone, right? Who wants their kid, suffering from an alcohol-related problem, right? But when I went on that TV show, when I was explaining about the work that we were doing, in terms of reducing alcohol-related harms among young people and so on and so forth, a few weeks later, believe it or not, I was at this shop trying to fix my iPhone, and the guy says, I've seen you somewhere, where have I seen you? And he was like, oh, you're the lady that's trying to create an alcohol ban for Lebanon. So again, I said, no, I'm not trying to ban alcohol in Lebanon. I'm trying to, have a policy framework that protects young people. So again, the reason we really emphasize participatory based approaches is because if you don't have the buy-in of, the community and the people, they're not gonna, none of these policies, right, are going to be implemented in an under-resourced setting. Why? Because we don't have enough the government doesn't have enough resources to monitor the implementation of an alcohol policy or a tobacco policy in all of the different pubs and restaurants and so on and so forth. So for Tobacco Law 174, which bans public smoking or smoking in public places, it really worked when the manager of the pub or the manager of the restaurant was convinced that, what, I don't want smoking to happen indoors, please, and so it wasn't the government trying to implement it or, monitor it. It was actually the fact that this person or this community member was convinced. So I agree with you in the sense that, in the larger scheme of things, that, participatory based approaches, might not seem, the most important component, but when you're dealing with under-resourced settings, when you're dealing with contexts where, the government has very little control or say, you want the buy-in of the community. And to do that, you need to engage them from the beginning in order not to sort of feel like a top-down approach, like we did everything, we just want it to be implemented. We engage with them in conversations about what might work, what might not work. Why do you think this is even a problem? And how do you think we should solve it together? Because that way, once you have the solutions, they'll be ready to implement them and they'll be your allies. So yeah, I hope that I've clarified that point.
Fascinating. Thank you so much. Any other questions from the class or the public? If you're joining us, please do type in your questions in the chat bar, and I'll pull them into the conversation. We have about 5 minutes left for this session. And if I may, I'd like to ask a question about legitimacy. So actually, I see Peter's hand. Before I go down this path, perhaps, Peter, would you like to chime in? You're muted. Peter, you're muted, so please do unmute yourself.
I'd like to ask a question of the students that you've got there, Dr. Hussain.
Sure. In fact, Peter, we're going to have an entire 25-30 minutes with them in about 5 minutes. So.
Oh, well, let's wait then. I'll ask them then.
Wonderful.
I'll keep them in suspense.
Thank you. So as a final topic of conversation for the public Q&A portion, I sense an issue underlying some of these lines of discussion we've had, that being this concept of legitimacy. So Lilian, you were just speaking about participatory approaches perhaps being useful because in your work you're trying to impact the world outside. So not only are you in a position to take evidence or data and mine it for possible value, but then you have to go deliver an outcome from it back to that external world, and perhaps a methodology that builds rather than transacts on legitimacy is more useful. And I wonder if that's one of the ways in which you run into legitimacy as a force that you're working with in your work. And Peter, you spoke, quite a bit in complexity about the role religion may have in legitimating certain pro-social, pro-health behaviors. And so therein again, we're discussing public health policies where we're looking to use religion and the legitimacy it has in shaping individual behaviors to change behavior. I'm just broadly curious about how you think about how you experience or how you utilize legitimacy as a factor in either your methods, in your theoretical work, or how you make sense of it and engage with the world in this topical world that we're discussing. How does legitimacy factor into your work?
Lilian, do you want to take that? No, okay. Legitimacy. Well, I agree with what Lilian said about we can't go in as experts from the top dictating what has to be done. First of all, say approaching mosques to involve them in trying to promote tobacco control. Well, how do we approach a mosque? Well, I think we need to be a bit humble. I think we need to say, well, what first is the standing of Islam? How do you see it? They may say, well, the Quran says we must not act to promote self-harm in any way. So that would be against the teachings of Islam. So we know, first of all, that they're on our side, if you like. Now, is it haram, forbidden, or is it makruh, discouraged? Well, does that matter too much? Is it what Freud called narcissism of minor differences? No, I don't think so. I'll tell you why I don't think so. Because the tobacco industry uses those different views to portray those who would take a tougher line on tobacco use, bans and so on, as Islamic fundamentalists, proto-terrorists, you name it, any kind of slur that can be thrown on it. And they try, the corporate lawyers of Philip Morris even have tried to interpret Muslim theology in terms of favoring tobacco use. So we try and learn from the religious authorities as much as we try and persuade them to come on board and take part in promoting smoking cessation. Okay.
Thank you. Lilian, any parting thoughts?
So I like that you framed it under legitimacy, and often when I'm talking even to my students and when teaching EPI and the importance of data and evidence and research, we often talk about legitimacy in the sense that I think part of the reason why there is a very weak research infrastructure in Lebanon and many other countries, neighboring and other countries, is because when you conduct so much research and then it doesn't give back to the community, you lose that legitimacy, right? So you've been asking me too many questions for so many years and I haven't seen any changes, right? I haven't seen any improvements, neither in the practices, nor the policies, nor the services. So I'm done with research, right? I'm done with you collecting information from me when you don't give me back what I deserve or what I was expecting. So, and then what happens is that, much of the research ends up being, poorly conducted and not so well conducted and not so well translated or published. So I agree with you. I think legitimacy is a very important point, and I call it credibility, you called it legitimacy, I call it credibility, in the sense that if we continue to work with communities and engage with them and collect data from them, but not give back to those communities. So that's another point. That's not just trying to get their buy-in, but that's trying to give back to, back to the community that has helped you with your research. I think you lose credibility, and then they won't engage, and then you won't be able to progress and generate the evidence needed for, policy planning and so on and so forth. So yes, I do agree that legitimacy is important. I do agree that participatory-based approaches are important, but I also agree that we should give back and, to the community. What we do here at AUB, once we bombard our students constantly with surveys and surveys and surveys, we at least try to, think about policy changes at the institutional level, right? So what could we offer for our students at the level of university health services that would improve their mental health status or substance, if they have any substance use problems and so on and so forth. Because the least we can do once we bombard them with all these surveys is that, improve the conditions at a smaller, sort of more local, contextualized level before we even try to change things at a national level. So I hope that, that answers your question. But yeah, credibility is very important.